Got the late night show this week. I did the early afternoon special, and now late night edition. Hope everybody's had a good day. All right, good evening, everyone, and welcome to a brand new episode of Know Your Pharmacist. Stream live this beautiful Thursday, February 22nd, 2024. I'm your host, Dr. Joaquin Acosta, not just the CEO of Pharmtrue, but a passionate advocate for transformative healthcare and secret knowledge in the vast world of pharmacology. Tonight, we delve into a topic that resonates with each of us: safety and innovation in our healthcare system. As we navigate through the complexities of modern medicine, we unite under the umbrella of understanding, collaboration, and progress. It's not just about the problems we face, it's about the solutions we create together. In our Pharmacist Frontline segment, we'll tackle a pressing issue that's disrupted our healthcare fabric: the recent cyber attack on Change Healthcare. Change Healthcare, a pharmacy switch. This incident isn't just a technological setback, it's a wake-up call to the vulnerabilities and the resilience of our healthcare system. We'll explore the impacts, the responses, and most importantly, the path forward. Our Tech Talk tonight will shine a light on the often overlooked but crucial element of pharmacy switches. Understanding these systems is key to appreciating the backbone of our medication delivery processes. It's about demystifying the tech that powers our health. In the Enlightenment Hour, we engage in a riveting discussion about the interplay between evidence-based medicine and public health. It's a debate that goes beyond academics. It's about how we apply science and intuition to care for our community. Our Herbal Wellness Corner is brought to you by High Horse Cannabis Co, where we explore the groundbreaking potential of cannabis in pain management. Is it the new frontier in replacing opioids for chronic pain? Let's uncover the facts together. We'll also spotlight the incredible community initiatives by the Peril College of Osteopathic Medicine in Las Cruces. Their commitment to health and wellness screenings is a testament to the power of proactive healthcare. And finally, in our Men's Health Minute, sponsored by Botto Speedway Park, we dive into heart health with leading cardiologists leading the way. Remember, taking care of your heart is an investment in your future. And February still happening, Heart Health Month. Very important. It's a month for a reason. So sit back, engage with us, and let's embark on this journey of knowledge, innovation, and community-driven healthcare together. We're not just watching the show, we're shaping the future of health. Let's get started. All right, welcome in, everybody. So, I don't know if anybody was dealing with their pharmacy today and having some issues. Those pharmacies who use the switch, what's called Change RX, they were down all day long. It was a big problem. Pharmacy owner, total nightmare. If you're a patient, total nightmare. So what happened, right? Check it out.
Discover hand-selected hotels around the world.
Not going to need to explain that, but guys, so Change Healthcare hit by a cybersecurity attack impacting pharmacies nationwide. Some pharmacies nationwide are reportedly experiencing outages due to an outside threat. Change Healthcare, one of the country's largest healthcare technology companies, reported its network was hit by a cybersecurity attack today. The statement indicated disruption is expected to last at least throughout the day, and they reported they were facing enterprise-wide connectivity issues starting at 5 a.m. Eastern today. Systems had to be disconnected immediately, they explained, and once they became aware of the outside threat, in the interest of protecting their partners and patients, we took immediate action to disconnect our systems to prevent further impact. Experts are working to address the cybersecurity issue, according to the company, and they noted that the issue is just impacting Change Healthcare, and all other systems across the big and vast United Health Group are operational. Change Healthcare handles orders and patient systems throughout the nation, and the disruption impacted filing claims for prescriptions, all across the country. Any pharmacy provider that was using Change Healthcare wasn't able to submit claims to the insurance. So, if you were a pharmacy, you might have had to get somebody their medication for today, either pony up the medication and wait for insurance to pay when all of a sudden, you can run that copay later. Big risk on high medications when, right now the pharmacy industry is really not reimbursing well on those insurances. And, the switch, That whole thing right there where you send the prescription billing information to the insurance and the insurance tells you if it's covered or not, how much they're going to pay for it or not. That's a very important system. Of course, they're a very big middleman for the data, but they're also either going to let you down, easy, or let you know if you perhaps made some money on a prescription, right? In the independent pharmacy world, they're letting people down easy quite a lot of the time. And it's a frustrating situation because, these switches are owned by the bigger PBM companies such as United Healthcare. And that's where we're kind of talking about it today. The big vulnerability of what happened with a cyber attack on the big switch. If you're a pharmacy and an independent, all of a sudden you had to somehow work around this and, you were subject to whatever was happening there. And scary, right? If you had to give out medications without being able to bill it in real time, right? So it's a very odd, scary situation for sure. And just something to take a good look at the nature of how this all works in terms of the pharmacy world. And I want to show you guys a little bit of a quick little too long didn't read post about what the heck is a pharmacy switch. So turning the light on the pharmacy switches in our tech talk today. So showing about this here tonight, wanting to show you a little more, lesser known about pharmacy claims and transactions. And let's be honest, there are many actors out there now touching pharmacy claims beyond the pharmacist, doctor, patient, and healthcare plan. This actor you'll never see or touch, but your pharmacy certainly has, and it's called the pharmacy switch, right? What is it? A switch essentially is the software that exists between your pharmacy and your pharmacy benefit manager, or that company that shows up on your employer's health insurance card for pharmacy benefits. The switch is basically the router or connector cop that links your pharmacy to the PBM. There's a few numbers on most pharmacy benefit cards that help the switch route the claim, which is the group number, sometimes listed as a GRP, or the number, or the bank identification number. Yes, because claim processing for pharmacy claims grew out of bank transfer technology. And lastly, the PCN, a processor control number, right? If you've been in the pharmacy billing world, voila, there it is, right? Whether you're a technician, a pharmacist on the insurance side, right? You've worked with those numbers before. And if you're a patient, you have to provide that information to your pharmacy. And if you don't have that on you, usually it's a really big pain in the butt to do things in a pharmacy and receive services, right? So anyways, in terms of talking about it, this is what happens, right? Pharmacy sends the claim out to eligibility and processing. The switch claims traffic to respective PBM based on the group, BIN number, and PCN number on your pharmacy benefits card, right? As you know, like Blue Cross Blue Shield has a billion different plans. The switcher is the one that routes it to the right plan, right? So, that's what means you can't submit claims to the insurance because your pharmacy software, which is supposed to talk to the switch, to get all this out, and they charge you for it every single time you send a claim. They charge you for it, right? And granted, even if it's a small amount of money, it happens over time. And so this vulnerable little portion of the system right here, hacked, right? Huge PBM, hacked, lots of data, hacked, big scary thing. And people may not be talking about the implications of that in general. And this is a big healthcare company, right? I know I don't know how long. I'm just curious how long you see people and lawyers and things starting to file big lawsuits for, have you had your data caught in a hack? Has your data been whatever? And, you can just go after these big corporations because you've been subjected to some of this stuff and you have proof of it. So anyways, I'm sure that already exists out there, but I'm sure it's only going to become even more because that sort of predatory thing is pretty ridiculous on all sides. But basically just looking at it, right? Who are the big switches? So there's Relay Health, owned by McKesson, the largest drug wholesaler on the planet since 2006. Online reports said they have as much as 75% of the switch traffic in all pharmacies as of early 2021. Keep in mind, they bought Cover My Meds, the online prior authorization service. So, that's almost another switcher within a switcher. The Change Healthcare, owned recently by United Healthcare / Optum, one of the big, largest 3 healthcare insurers. The acquisition was announced in 2021, recently finalized in October 2022. And the same online resources tout that Change controls 25% of all switch traffic in pharmacy as of early 2021. My only experience ever working and setting up a switch in a pharmacy has only been with change. So, they've been good to me. I wasn't running any pharmacies today, thank God. But this is something that you're going to have to look at, right? There's not very many switches that, are contracted out. When you're talking about maybe the big ones, you're going to be seeing a lot of in-house stuff for your Walmart, Walgreens, CVS, Sam's Club, Rite Aid. They all have their own in-house, connections. And it's a very interesting situation because, it is insane because, as you see here, whoever controls the switch controls almost the near final say in a prescription's cost and coverage data. And that's actually truly true, right? So, owning the switches, you are, yes, gatekeeping what the insurance has to, be coded for in terms of reimbursing or approving or denying or whatever it's going to be, right? So you are the gatekeeper for that. And there's instances in, certain states or whatever it may be, a provider that, you cannot have any sort of lock on that minus whatever insurance and switch process has. And when, those two are seemingly a conflict of interest, and when you've got three switches and, three big insurance companies that pretty much run the entire system of our American healthcare prescription, at least system, it's very insane. So pretty much just a lot of stuff to chew on. But if you were, having to deal with that situation today, having to deal with a pharmacy whose switcher was down, at the end of the day, this has nothing to do with pharmacies. About half of pharmacies probably in the countries were, unable to process claims today. So, be kind to your pharmacy staff, truly not their fault, regardless of whatever pharmacy staff you had to deal with on that. If they worked with you to get prescriptions out and maybe get copays on the backside for regulars where things are a thing, sure. But, there are situations where that is almost damn near impossible, especially when you have an expensive medication that you may not have any clue for, right? And it's nobody's fault that, you couldn't talk to the insurance. Your pharmacy software couldn't talk to the insurance that way, right? So crazy, for sure. Move on to Enlightenment Hour. Pretty interesting kind of thought to ponder here. The light, shining the light on evidence-based medicine and public health. Interesting concept here, right? So take a look at this. It's a familiar pandemic story. In September 2020, Angela McLean and John Edmonds found themselves sitting in the same Zoom meeting, listening to a discussion they didn't like. At some point during the meeting, McLean, professor of mathematical biology at Oxford University, Dame Commander of the Order of the British Empire, Fellow of the Royal Society of London, and then Chief Scientific Officer to the United Kingdom's Ministry of Defense, sent Edmonds a message on WhatsApp. "Who is this F-wit?" she asked. The message was evidently referring to Carl Hennigan, director of the Center for Evidence-Based Medicine at Oxford. He was on Zoom that day along with McLean and Edmonds and two other experts to advise the British Prime Minister on the COVID-19 pandemic, and their disagreement recently made public as part of British government inquiry into the COVID-19 response is one small chapter in a long-running clash between two schools of thought within the world of healthcare. McLean and Edmonds are experts in infectious disease modeling. They build elaborate simulations of pandemics, which they use to predict how infections will spread and how to best slow them down. Often during the COVID-19 pandemic, such models were used alongside other forms of evidence to urge more restrictions to slow the spread of disease. And again, meanwhile, is a prominent figure in the world of evidence-based medicine, or EBM. The movement aims to help doctors draw on the best available evidence when making decisions and advising patients. Over the past 30 years, EBM has transformed the practice of medicine worldwide. Whether it can transform the practice of public health, which focuses not on individuals but on keeping the broader community healthy, is a thornier question. During the COVID-19 pandemic, Hennigan and other several prominent EBM thinkers became very influential critics of pandemic policies. The specifics of their critiques vary, but certain themes emerge. Again and again, they've argued that public health leaders like McLean rely too heavy on error-prone models, biased evidence, and simple intuition when making consequential decisions. At the same time, they say those public health experts did little to gather rigorous data to back up their claims about the usefulness of interventions like mask mandates and school closures. At stake are deep divisions over how scientific evidence should be used to make decisions. And whether or not you're Republican or Democrat, how we use science to, manipulate our public sentiment is definitely something worth consideration for sure, right? And so you look at that, even the scientists are perhaps disagreeing, right, in some of these regards. In response, some public health experts and physicians, including other prominent people in the EBM movement, have argued that researchers like Hennigan and his allies have overstepped their bounds, making unreasonable demands on public health that can be used to further political agendas. Versions of this debate pop up regularly over masks, school closures, and even in areas outside of pandemic policies, such as treatment for children experiencing gender dysphoria. Taken alone, each can be understood as its own little flashpoint, but there's a bigger debate underway, one that has profound implications for the future of public health practice. At stake are deeper divisions on how scientific evidence should be used to make decisions, says Jonathan Fuller, a physician and philosopher of medicine at the University of Pittsburgh. Until we have a better handle on them, he said, I think these particular flashpoints are going to keep coming up. A foundational tale of the discipline of the public health story about the triumph of sharp observation. During an 1854 cholera outbreak in London, physician John Snow, mapped the location of cholera deaths in the city. He noticed that they clustered around a specific water pump and reasoned correctly that the disease spread via contaminated water, and it was a life-saving insight. In contrast, the foundational tales of EBM are stories of how fallible human observation and reasoning can be. Since at least the 1970s, for example, some physicians observed that women who took estrogen and other hormones after menopause seemed to have lower rates of heart disease. Hormone pills were given to millions of women, at least until rigorous experiments suggested that some women getting hormone treatments were actually more likely to suffer a range of harms, including heart attacks and breast cancer. Today, the situation appears to be more nuanced. Evidence suggests that treatments are safe, even beneficial for some women, but may carry unforeseen risks to others. The 1992 paper by a group of physicians spelled out the solution to what they saw as a misguided medical approach and helped launch the EBM movement. The paper presented a scenario. A junior medical resident sees a patient who has suffered a seizure for the first time. There's no obvious cause. The patient wants to know the odds that he will have another seizure. One approach, the group writes, would be for the resident to ask a couple senior doctors to provide her with an educated guess based on their experiences. Such an estimate is not necessarily imprecise. The patient leaves in state of vague trepidation, the group wrote. They labeled the approach the way of the past. In the way of the future, the young doctor skips a consult with her superiors and instead goes to a computer. She performs a search in a database of medical papers and finds 25 different published research papers on seizures recurring. She scans through them all and identifies one that actually collects and crunches data about how patients fare after seizures, providing a more precise estimate of how likely the man is to have another episode. The doctor conveys that risk to the patient who leaves with a clear idea of his likely prognosis. The goal, the EBM pioneers argued, was to bring the best available evidence more squarely into the practice of medicine. Perhaps predictably, older physicians were not always elated about a movement devoted to de-emphasizing intuition and unsystematic clinical experience, in the words of the 1992 paper. It probably didn't help that David Sackett, the physician widely described as the father of EBM, seemed to relish challenging authority. Always happens in these kinds of situations, of course. He's a nice guy, but in your face, recalled Jeffrey Arson, a physician who worked with Sackett in the 90s at Oxford. He didn't hold back. If he thought you were in the wrong track, he'd tell you no in uncertain terms. Younger doctors at Oxford, Aronson recalled, seemed to enjoy something of the iconoclasm that he brought. But Aronson added Sackett rather raised hackles among the senior members of the division and died in 2015 at the age of 80. Despite the pushback, the movement was quickly influential, but bringing the best evidence into medical decision-making is challenging. There are more than 1.5 million papers published each year in the biomedicine and life sciences by one recent estimate. Just a single search paper in a popular database can yield thousands of different studies and analysis. Figures were less extreme but overwhelming in the 90s. How should physicians sift through it all? To address the problems, EBM practitioners created methods for evaluating the quality of scientific studies, in essence, ways to grade evidence, right? They teach you these things when you're in, secondary, post-secondary graduate school, right? How to do evidence-based, medicine, basically, right? You're looking at journal clubs, how to read articles and tell others what you think about it and actually have good reasoning behind it using, stats, right? And actual data. So, talking about this here, says a researcher to know whether estrogen hormones prevent heart disease in postmenopausal women. In one kind of study, researchers explain how estrogen seems to affect the heart and why it's plausible that taking hormones would prevent heart disease. EBM approaches would rank the evidence as relatively low quality better according to an EBM observational study in which researchers effectively surveyed women who already use hormones and those who didn't to see who has higher rates of heart disease. But even then, there are potentials of bias, right? Maybe the kind of people who take estrogen hormones are also the kind of people who exercise more. And it's actually the CrossFit sessions and the yoga classes, not the estrogen, helping their hearts, right? The gold standard for research on clinical interventions, according to EBM, is the randomized controlled trial. In an RCT on hormone replacement therapy, for example, some women would be randomly assigned to get hormone therapy, some would take placebo, and researchers would track their heart health. As a general rule, EBM practitioners have pushed for medical decisions to be grounded in high-quality RCTs whenever possible, rather than other forms of evidence, even though good RCTs can be slow and costly. Once doctors have decided how to identify high-quality research, they then need some rigorous way of finding all those studies. Amid the millions of published papers available in the 80s and 90s, EBM practitioners helped develop something called the systematic review. They would comb through thousands of papers and then use a transparent method to rank all the evidence and synthesize it into a clear, simple conclusion. Basically, an exhaustive evidence inventory. That way, a physician with a question doesn't have to do all the searching themselves. They can simply refer to the systematic review. EBM practitioners created methods for evaluating this quality of scientific studies. In essence, they were coming up with the ways to grade the evidence. The most influential group that makes such reports is the Cochrane, founded by the EBM pioneers in the 90s. Cochrane has today published thousands of reviews, and they're widely used to inform medical decisions. Along the way, EBM movement also developed a certain culture. We tend to be skeptics, said Gordon Guyatt, who coined the term evidence-based medicine in the early 90s as a physician researcher at McMaster University in Canada. Somehow attracts people with skeptical bent. Often, EBM-oriented researchers have directed that skepticism towards medical interventions that they feel are based on thin evidence. Indeed, over the years, EBM researchers have challenged certain kinds of cancer screenings, the use of specific drugs for certain treatments, and certain post-operative practices, successfully revising their role in medicine. One of the things that evidence-based medicine is kind of pushing back against is an unbridled interventionism, said for the Pittsburgh medical philosopher who has written about the history of the movement. If the standards of evidence are too low, you're going to have lots of interventions because there's a lot of interested, invested parties that want to sell you things. Raising the standards of evidence, as EBM aimed to do, will necessarily challenge some of those treatments, he added, and one result is becoming less interventionist than you would have been before. Cough, cough, the opioid epidemic in this country, where evidence-based medicine was used to pretty much drug up a very, very large amount of our country. Today, experts debate whether that skepticism towards interventions went too far in the COVID-19 pandemic. When COVID-19 spreading worldwide in the early 2020s, public health leaders were faced with a difficult set of choices. They had very little information about the new virus and at the same time, tremendous pressure to act quickly and slow down the spread. Authorities used what evidence was available to make decisions. Computer models suggested that measures like school closure might slow down the spread of COVID-19, schools closed. Some laboratory and clinical evidence suggested masks would slow down the spread of COVID-19 and mask mandates were soon in place. Among researchers, it was no secret that the evidence behind many of these measures was less than ideal. Computer simulations are prone to error and fraught with uncertainty. While there was no good reason to believe masks to probably slow the spread of the virus, there was inconclusive evidence that masking policies would actually blunt the impact of a pandemic pathogen. Communities of scientists soon fractured over how exactly to deal with all that uncertainty. Already in the spring of 2020, some evidence-based medicine figures were expressing concerns that public health authorities were acting too aggressively on weak evidence, including models. Fixation with modeling distracted from an evidence-based interpretation of the data. And again, the Oxford professor and target of McLean's WhatsApp epithet later wrote. Right? And I know how political some of this may feel based off of our intense memory of the situation, but let's try to look at it from a data perspective, right? Evidence is lacking for the most aggressive measures. John Ioannidis, a health researcher and evidence-based medicine luminary at Stanford University, wrote in March 2020 in an editorial for a scientific journal. Research on previous respiratory disease outbreaks, he continued, found scant evidence to support practices like social distancing. Most evidence on protective measures come from non-randomized studies pro bias, he wrote. Some people in the world of public health fired back. That kind of EBM perspective, they argued, was simply unrealistic in a moment of crisis, and Ioannidis doing his best about the standard evidence is not helpful. Yale epidemiologist Greg Gonsalves wrote on Twitter, X now, but he said that in March. We want better data, and if you don't have it, you sit and wait for it in a pandemic. So of course, we're reflecting on the situation. What was there to do? You had to respond. You had to do. Feel like you have to do something, right? And so, obviously, interests and things start happening. Of course, I took the vaccine. I'm multiple times boosted. Evidence at the time, yes, we did what we could. I'm not using this as a platform to back off on the vaccine, but I want to reflect on the approach of how we analyze data and use it to influence, things happening. This is obviously something that happens in a neutral, Oxford public health environment where, we are over the pond. Of course, you have, political agendas on whatever sides of the coin that you have. But at the end of the day, science should be science, right? Science shouldn't be politics. And so you do really think of a lot of considerations there where, the United States of America has been swindled by, opioid corporations marketing hard to doctors with particular studies to influence opioid prescribing, to overprescribing, to creating a situation where the United States consumes 80% of the world's opioid supply, only being 5% of the world population. Doesn't make any sense. We're the only country in the entire world that has this problem because we were duped by evidence-based, misbranding, just so much insanity, right? So, is this a good reflection to still have and that's going to have in regards to COVID-19 going into the years? Absolutely, right? We're going to see whatever, effects happen to however anybody can attribute, actual causation of effects of the shot, versus correlation, anything like that, sure. Whatever that may be. There's paranoid, conversation about, the thickening of things in the arteries and some of those blood clots. And I can't attest to any of that. Not the conversation I'm even looking to have, right? I think, some of those things can be quite politically, pushed. And when we're looking at science, we gotta be looking at, numbers and things there. And this was a very interesting reflection of a public, display of the conversation that really does need to be had. And COVID was just a place to expose it for what it was, for sure. And that's my thoughts on the situation. So now let's move on, right? And talk about some real, data that's worth talking about. I'm looking at, can cannabis be used to replace opioids in chronic pain patients? Well, some data. Cannabis for treatment-resistant chronic pain, open label, longitudinal, 7-month trial, 176 patients, 73 on opioids at baseline. Looking at all this, right? 20 grams of cannabis given monthly, smoked cookies or olive oil. Patients given titrations instructions up to 3 times a day. Encouraged to attempt gradual dose reduction of other analgesics, especially opioids. So take a look. Results of the study: improvements in pain and pain-related quality of life scores. 44% of those taking opioids discontinued. Medical cannabis associated with decreased opioid use in chronic pain patients. Cross-sectional retrospective survey of 244 medical cannabis patients with chronic pain in Michigan. Cannabis use associated with 64% decrease in opioid use, 118 people. Decreased number and side effects of medications and improved quality of life, 45% of people. Survey data: out of 542 cannabinoid opioid co-treatment people, 39% stopped opioids completely, 73% for greater than a year, 39% reduced dose, 47% reported greater than 40% pain reduction, 80% reported improved function, and 87% reported improved quality of life. I was looking at it all there, right? Associations between medical cannabis and prescription opioid use in chronic pain patients. Super cool. So let's look at substitution for prescriptions. Big things here. What can cannabis have interventions in? Pain and mental health medications right here, opioids, benzos, antidepressants, and other medications. Those 3 classes of medications alone do damage, right? In a lot of ways. Antidepressants being the least that I'm attacking there. The controlled substances in that group, opioids and benzos, big deal, addictive and habit forming. So anyways, looking at this study, who was able to substitute, out of 1,500 people study in New England, 40.9% were able to substitute opioids with cannabis. 38.6% were able to substitute cannabis for their medications for anxiety. 32.2% able to substitute it for migraine. 37.5% able to substitute it for sleep. 25% to substitute for alcohol, and 15% to substitute it for antidepressants, right? Interesting. So, a lot of good data there. Another study: 791 response to medication regimen question at 6 months. 18% stopped using opioid analgesics or reduced their dose. 4% increased the dose of opioids or began using them after the initiation of cannabis treatment. Interesting, right, guys? So you look at other drug substitution: opioids, benzos, gabapentin, NSAIDs, DMARDs, SSRIs, SNRIs. Changes in pain and health since starting cannabis. Those who are on all those medications. Very interesting. Who is actually experiencing some decline. Males and females who had a little decline. Who had improvements, in their health on the right side. Changes in pain since starting cannabis on the left side. So very, very cool. So can you substitute cannabis in a lot of situations? There are a lot of things that have been manipulated by perhaps some evidence-based situations, right? And we had, drug approval takes a lot of time, but because a lot of time takes a lot of money, in those situations, you could probably consider the fact that when you have to make sure that your investment goes through, there's obviously some influence. And as you see, pharma has been influencing lobbying and politics for, many generations, right? So things happen that way for a reason. So let's move on. Community Spotlight brought to you by the Big Chicken Farm. Talking about the Peril College of Osteopathic Medicine. Wanted to share Friday, February 23rd from 8 to 12 in City Hall of Las Cruces. Kick off your weekend with free health screenings hosted by the Peril Ophthalmology Association, providing information on overall wellness and preventative care. From 8 to 12 a.m., free screenings information: blood pressure, blood sugar, A1C, cholesterol, vision, and body mass index. Guys, I'm telling you, if you're in the public and in the community, go take advantage of this kind of stuff. Seriously. Where you have to wait, really long periods of time to go get appointments, to go, see providers. Having some really personalized time to talk to a student could really be worth your time, especially if you've got some medical questions. on deck there. So go get the health screenings. Go get them done for free. No reason. City Hall Friday. It's 12. Last thing in our men's health minuto tonight. Got a cardiologist I wanted to share this conversation here.
Wide.
Oh, yeah. So this morning, we took our heart questions to the expert and got a little workout in at the same time.
It is really safe to exercise when you have heart disease. The question is how safe and how much to actually do.
Men are from Mars, women are from Venus. We're different. We are different. How does heart disease differ?
Yeah, so what we know is that most of what we call the classic textbook presentations for heart disease is mostly in guys. Women appear to have different presentations of heart disease, but they still have heart disease. The things that matter when you're exercising is it's really about how you're feeling. And part of how you're feeling is based on what type of training are you trying to do.
It was over a course of time I realized something was wrong. And then I was working out and I noticed that more that I leaned forward, I started to get dizzy. Like I was gonna fall over.
Yeah.
But prior to that, I just thought, like we say all the time, oh, it'll pass. I'd sit back down on the bench a little bit, take a little bit more air, and then I get up and I was fine. But right now? Well, right now I would have kept going. Bam!
But I think it's one of those things, like you said, right, is that we often don't know, is this fine, it'll get better because I'm getting older? But I can't say that as a doctor until we rule out all the other stuff. We know that people that have heart attacks when they could have a sudden death event, it could be doing any day activities, it could be exercising. It's a lot about knowing what your numbers are and making sure your numbers and your overall health is taken care of.
I started 2.5 miles an hour. Is it best to start low and go up? Or should I, when I get on the treadmill, punch it right on up to say 5 and let's go for it?
I would definitely recommend going slow and increasing as you can tolerate it.
Okay. Well, right now I can't tolerate it anymore. No.
Yeah, so you're at a perfect spot then. You picked the perfect spot to start at. And so the nice thing about when you're doing strength training is that a lot of those symptoms that we talk about when you're doing cardio don't really apply as much when you're lifting. Because when you're not kind of pushing the heart as much. But the nice thing is that this type of exercise is really good for heart health in the long run.
Like, so you're watching this right now, you're like, oh, am I on the edge? I've had a little shooting pain here and there, or just tightness. When do you seek help?
I think it's never wrong to seek help. It's one of those things that you just never know, and all of our bodies are completely different. And seeing a doctor and making sure that you're all taken care of.
Just like we did, right?
Yeah.
All right, so it's also worth noting that sleep, hydration, and diet are extremely important when it comes to keeping a healthy heart.
I think one of the things that we learned was, if we say it all the time, see something, say something. In this case, feel something, say something. Don't think that it'll just pass and I'll be okay, because it could be the sign of something deeper inside.
Yeah, like you had as well.
Yeah, I dealt with the blood clots in my lungs, thinking that, oh, just a little winded, but no, it was a serious situation, and that does affect the heart as well, as far as the heart pressures go.
Yeah, well, you got a good workout in, I saw.
Yeah, he kept going.
No, 5 minutes.
All right. So that is it. Thank you for joining us on this enlightening journey. Remember, your health, knowledge, and empowerment are our top priorities, so stay tuned, stay informed, and let's transform healthcare together. This is Dr. Joaquin Acosta signing off. Till tomorrow, stay healthy and inspired.